Okay, well, welcome back, everybody. We're starting session 2. This is improving uptake of recommendations on low-dose CT, not directly related to lung cancer. Pleased to have a wonderful panel joining us that will include Minal Kali, Joel Fafi, Vicki Beckler, and Ethan and John Reyes, and they will introduce themselves after I give the opening talk. So I'll start off with this session of the topic of which ones are being reported and are they impacting management. I'm David Yankelowitz. So next slide. These are my disclosures. Next. I want to start off discussing an article. In 2010, these 3 articles were published in the journal Radiology. The first was by Budov on bone mineral density. All of these were add-ons that were found where we looked at, well, for other reasons. Scans were done for something else, but we found that we could gain additional information. So again, the first one was on bone mineral density that was seen in coronary calcium scoring. The second was on low-dose CT screening, was the scan, and they found that they could do ordinal scoring of the coronary calcium. And that was an LCAP study. And the third looked at aortic findings on chest CT scan to predict vascular diseases. Next. And that led to the following editorial, which I think, again, in 2010 was prophetic. And I want to just read a few of the quotes from this because it really kind of foresaw what was coming. Next. These are some of the quotes. These reports suggest a change in the paradigm from merely reporting the imaging findings, taking an extra analytic post-processing step to create and report numeric findings that may help to assess the patient's risk for cardiovascular disease or osteoporosis. Next. First, is this additional information actually free? And if it is, and if it's not, is the cost worth it? Second, will this additional information actually have a positive effect on patient care? And third, should we report the screening findings for every diagnostic exam? And if these approaches hold true, and we do not report such findings, could we be implicitly ceding part of imaging interpretation to other specialties? Next. Next slide. And if we believe such information is of value to patients, either individually or on a population basis, it is our obligation to report it for everyone. Perhaps, but it may be that supplying data on future disease risk is inappropriate or useless for certain populations. By placing an unrequested report of increased disease risk in the medical report, we may unknowingly lead to insurance companies denying life or disability insurance. This is from 10 years ago. All of these questions are now really reaching the forefront now, and they're getting even more important. So, next slide. This is just the beginning of where we're heading. All of these areas are being evaluated, especially cardiovascular disease, osteoporosis, but in fact, breast diseases are coming, metabolic syndrome, all of this is coming. Next. Additional findings. Well, I just want to give you a little bit of background on this. It's been reported, and they're not the greatest studies, but there's a large range of reported findings that are not clinically relevant, range from 8 to 94%. And probably there'll be findings, we'll find findings on every single scan outside of what was looked for. And clinically relevant, it's reported to be substantially smaller. Some reported as high as about 20%. Next. Next. Yeah. And you see, prior, and you just see that it's gotten, prior slide. You can see it's gotten a lot of attention in the literature. The naysayers will say things like, it questions the value of lung cancer screening when the incidental findings exceed the findings by 40 to 1. Next. Now, this came from the Nepson study. Incidental findings found in 81% considered clinically relevant, and only 1% with 0% ultimately found to be significant. Based on our results, we advise against systematically searching for and reporting incidental findings. Now, this is back in 2007. I suspect that they've changed their mind since then. Next. And this is from our leader of this meeting. Medicine is rarely gifted with such a high value opportunity to move beyond the individual disease silo to better manage these shared comorbid conditions. Next. So to have a positive clinical impact, the finding has to be made, it has to be acted upon, and it has to be clinically useful. Next. Well, what about COPD? We're reporting that. Now, here's the U.S. Preventive Services Task Force recommendation regarding screening for COPD. They give it a D recommendation. And the D recommendation means that there's evidence that it's probably, not only is it not good, it's actually harmful. Now, there's a lot of nuance to this, and it wasn't in the context of screening for where you're looking for emphysema. But it gives pause, and certainly to get them to recommend including this in the screening context is going to be a challenge. Next. And similarly, when it comes to cardiovascular disease, the U.S. Preventive Service gives it an I, meaning they just don't know whether it's useful or not. The evidence is equally balanced, whether or not we should even be reporting. Now, in both of these situations, we are reporting. Lung cancer screening has made the decision that we report emphysema and we report coronary calcium scores on everyone. So while the U.S. Preventive Services may not be recommending it, we're doing it, but it's not happening in all countries. Some countries, they're specifically saying do not report these things. Next. So these are the U.S. Preventive Services recommendations currently. Osteoporosis, they are saying we should screen for, and in fact, we can do osteoporosis screening on low-dose scans. We can even get, and there are products now that have been approved by the FDA, the DEXA equivalent. Breast density is also now recommended on mammography, not recommended, it's a legal requirement now that you report breast density. And we can do as good or better on CT scans to report breast density. Right? Some programs routinely report breast density. Next. This was a paper that was written by members of the group here regarding emphysema and why we should be doing it. And they make a very strong argument that we really need to be reporting. You know, the argument against it was maybe there aren't such good treatments for it, and that's always been the argument with emphysema and either screening for it. But this article lays out the rationale for why it's critical that we report it on our low-dose scans. And next slide, which I think is about the end. This was from David Marin's group, where they're demonstrating that there really is a value in looking for coronary calcium on CT scans of the chest outside of the context, and they're designing a major trial, which hopefully will get started soon, to really prove just how beneficial this actually is in reporting incidental coronary calcium scoring. Next. Here's where we start really getting into the sort of challenging stuff. We can start finding other things now. We can look at body mass or body composition, and we're starting to be able to predict things. Some of it's really wonderful. You know, you can predict how well a person might do if they have lung cancer and they're treated, whether they'll have recurrences or not. But all of this kind of body mass composition and others, they can start predicting mortality. When do you start including this in a report? This is really tricky stuff, because you may be giving people information that they don't want to have. And maybe we shouldn't be reporting some of this. The AI, and how good does the AI have to be before we start reporting? I mean, we're reporting coronary calcium scores, And as you heard, we're still waiting for the results of randomized trials. Can you imagine if we start reporting, your chance of dying in the next X years is such and such? It really gets to be complex, and it's going to require a lot of collective decision-making before we really know how to use this information. Next. And so I just made these points about whether or not we should be reporting all of these things. Next. So additional findings will be made with increasing frequency, clinical impact implies diagnostic and therapeutic options, and this is a rapidly changing subject to many additional factors. As we expand our prediction capabilities, we need to consider how this information is being presented. And with that, we will turn to our panel. And I'd like each of the panel members to give a brief introduction of themselves, starting with Minal Kali.
Hi, good morning, everyone. My name is Minal Kale, and I'm a colleague of Dr. Yankelevitz's at Mount Sinai, where I practice primary care, and I also conduct clinical research related to lung cancer screening, and it's really a pleasure to be a part of this discussion.
Joelle.
Hey, good afternoon. Good morning if you're on the West Coast. My name is Joelle Fatih. I am a nurse practitioner, former clinical program director for tobacco-related diseases and lung cancer screening programs and smoking cessation programs. Currently serve as a primary care provider in a community health clinic, professor of nursing at the University of Washington, and my full-time job is serving as a chief healthcare delivery officer at GoTo for lung cancer.
Next is Vicki Beckler.
Hi, I'm Vicki Beckler. I am a nurse and formerly ran a large lung cancer screening program. I've been in this space for quite a while, transitioned to industry recently, and although I'm currently employed at AstraZeneca, I lead their U.S. Lung Ambition Initiative, focused on early detection, outreach type things. Any information that I share with you today or comments that I share are going to be my own personal opinion based on my personal experience running a program and helping centers across the country build their programs as well in previous industry roles.
And finally, we have John and Ethan Reyes.
Hello, I'm an intern at Coraxial Technologies. I'm Ethan Reyes. This is John Reyes, my father. He's been helping me with our research.
And Coraxial, by the way, is a company that Rick Avila runs, and he has recruited the best and the brightest to help him with some of these really terrific projects that he's doing. So let's kick it off. The format will be, I'll sort of direct it maybe to one person, but everybody, all the panel members, I'm sure will have things to say about it. So let's just start off with me now. Are clinicians thinking of it as lung screening, or instead are they really thinking of this as multiple screens when they actually order the exam?
I would say that primary care clinicians are thinking of this as lung cancer screening, and the additional findings that are reported are not always acted upon, such as the coronary artery calcifications or the findings of emphysema. And I think that once that there's enough evidence to identify those findings as potential benefits of lung cancer screening, and that language makes its way into the recommendation for lung cancer screening, there will be much more of a conversation about what the value of lung cancer screening is in terms of these additional findings. But the current, I would say overwhelmingly the current practice is not to really discuss that we could see coronary artery calcifications or that we can see emphysema or that it's equivalent to DEXA scanning for osteoporosis screening in patients for whom we would be ordering that type of screening. So it's really not on the radar of PCPs. And, as we know, patients also aren't aware of this.
Great. Now, I think I just want to mention that there will be another session later tomorrow that Mary Pasquinelli is going to be leading, and they're also going to be following up on this. So this, I'm hoping, is going to be a sort of a lead-in to her discussions, and I think you'll hear some differences. You'll see big differences in terms of this kind of a response, and how it is in different parts of the country. Again, to Manal, when you get these reports, do you take them seriously? Do you think when I report that somebody has osteoporosis on a low dose scan, do you think they take that seriously? Or when we say there's emphysema, do you think it's taken seriously? Or coronary artery, has a high calcium score? Do you think that it's something, you get the idea?
Okay, so I will say that because we've, up to now, there's been a lot of discussion about the coronary artery calcium scoring. And I think that there's some, obviously many of these patients are already high risk based on the pooled cohort equation, risk calculations, and they've already been prescribed a statin. So I think there's an underappreciation of the utility of using the finding of CAC, for example, to educate patients about adherence to a statin, if not to, initiate the statin itself. So I think there are areas of opportunity that are not being seized, and not that it's not taken seriously. I just think that, ultimately most clinicians are ordering a lung cancer screening to look for nodules, and to look for lung cancer, and everything else is not fully appreciated, not that it's not taken seriously. And I think that if there's more, if the science supports that we can, with as much sensitivity, diagnose osteoporosis with a CT of the chest as we can with a DEXA scan, then that finding would be, I think, more acted upon or utilized. And I think as of now, there's an underappreciation of whether, is the osteoporosis that's diagnosed on a lung cancer screening low dose CT, is that equivalent? Should I, do I use this? Do I act on it? Do I start prescribing a bisphosphonate for patients who have, osteoporosis on parts of the spine that we're not generally even testing for bone density? And is that, is osteoporosis in the thoracic spine the same as osteoporosis in the lumbar spine and the hip so I think it's not that it's not taken seriously. It's like a little bit of lack of clear knowledge and guidance.
Now, I just want to add a couple of thoughts to this. And this is where actually organizations such as FDA will have a big role. The FDA has recently approved looking for osteoporosis on low-dose CT scans, even of the chest, as being DEXA equivalent. And this actually has just been installed in Mount Sinai and is actually going live shortly. So it will be really interesting to see how it impacts our clinicians' view towards looking at this. So this is where the technology and approvals, I think, are going to be very important. And we'll talk about that a bit in the next session. But I wanted to get a little feedback on this from Joelle and Vicky from what you've heard so far. Please.
I think that most of the time, it's interesting, if you're doing just a coronary calcium score or a DEXA exam, usually you've got a provider on one end waiting on the results to take action, versus a lung cancer screening, you're kind of looking for lung cancer, but it's the one exam, there's a variety of different ancillary findings that you're going to see. So it's important to differentiate what is clinically significant on these findings, these ancillary findings, versus those things that are not clinically significant. So I think sometimes we may get inundated, or clinicians, or it can kind of get taken for granted that you've got all these findings. It's like, oh, it's just routine. You're going to find a lot of ancillary stuff, and it's not all super significant, but many of the findings are significant. And I think for the most part, they do get acted upon when appropriate.
Joelle?
Yeah, well, I will say that the way in which a program is implemented can facilitate this opportunity. So my experience in a centralized lung cancer screening program allowed me the opportunity to actually review the results with the patient and have the patient in the office looking at those films. That also afforded me the opportunity to really kind of conduct a comprehensive review of systems and physical exam, which really helped me understand, you know, the findings that I needed to really kind of chase and take seriously. But it also afforded the opportunity to leverage the conversation in real time around what the risk assessment looks like, what their stratification for, you know, coronary vascular disease might be, but also to take it to the next step, which is to have a discussion around how to intervene, how best to prevent, or you know, support them in their health goals. So this is obviously complex because you really can discover a lot of things, including when you start asking people about whether or not they've got evidence of peripheral vascular disease, claudication, you know, chest pain. And interestingly, many of these people had more symptomatology and findings on physical exam, including surprisingly claudication and peripheral vascular disease more commonly than I expected when evaluating this particular population, where about 50% of them were currently smoking. I will say, you know, then there are some fuzzy areas like Manal brought up, which is we really cannot calculate a FRAX score looking at, you know, bone density and evidence of osteopenia or osteoporosis on lung cancer screening. But we know that generally anyone who is eligible for lung cancer screening is in a much higher risk group, particularly if they are 40 and older in the perimenopausal, postmenopausal state. And so, you know, their risk for heart disease, bone disease, lung disease, as we know, is exponentially higher, 2, 4, 8 times greater if they have a significant tobacco history, and certainly if they're currently smoking. So, you know, I understand what the USPSTF has put out there, but I do think that I am a believer that we need to harness this opportunity to really examine these people and capture this opportunity to dive a little bit deeper and determine if they have symptomatology that, you know, is evidence of some stage of the, you know, that would meet the criteria for the gold standards to identify people and treat them aggressively for COPD, for example. I think there's so much work that needs to be done here.
So let me ask a specific question to, you know, we've already known by looking back at our low dose scans, we did a review and we found that there's a substantial percentage of people that have even severe emphysema on the CT scan that don't know it. They're just totally unaware, which, you know, really surprised us. And actually, and even large, you know, when you talk about moderate emphysema, it's, you know, 30% of the people, and they're unaware of it. When you get reports of severe emphysema on a patient, do you kind of routinely tell them that they have this? Do you do anything about it? Do you say, hey, get pulmonary function tests? Or is it just kind of, okay, nice to know?
I think it's only very recently that the reporting of emphysema is now kind of triggering a reflex to inquire about respiratory symptoms. And until very recently, I didn't act on the finding of emphysema. And I think that generally to Joelle's point, which I really appreciate, which is that we don't do a full symptom assessment. And we certainly know that there's a vast issue with underdiagnosis of COPD. And, you know, the CT finding of emphysema, and I know there are other biomarkers of COPD in terms of airway wall thickness and mucus plugging that, you know, is still kind of being investigated that we could potentially use as triggers to screen for respiratory symptoms, which, you know, for a variety of reasons is not being done. And there's certainly the issue of kind of underreporting and patients' kind of lack of awareness that these symptoms that correspond to poor respiratory function are not just a function of aging or a normal consequence of smoking, but actually represent pathology. So, yeah, I just want to echo that, you know, I would love the idea of using the findings to trigger certain respiratory, you know, certain symptom assessments. Because at this point, I don't believe that that's being routinely practiced.
My last direct question to you, Minal, or Joel, you wanted to say something?
Yeah, I just wanted to kind of build on that, which is, you know, I've seen thousands of patients on the front lines in this setting. And it's often been really shocking to me how many of these people might have extensive evidence of emphysema on imaging. But once I sent them off to PFTs and, you know, retrieved those results, in many cases, it was very clear that their FEV1 to FVC ratio did not qualify them for emphysema per se. And to build on what Manal just shared, you know, people often will have the clinical symptomatology of COPD and really truly benefit from those PFTs. And I can think of a lot of other examples where in clinical healthcare, where a finding shows up on any type of imaging and we will act. And it's interesting because I feel like when it comes to evidence of emphysema, for example, and when we take a look at the USPSTF recommendations for COPD screening, you know, it's not strongly encouraged to send people off for testing, and yet we have an incredible opportunity to impact people's lives in the short term and the long term, quality, quantity, and when I think about people being at risk for lung cancer, it's a scary deal. But when you witness people suffering and then dying from COPD, it's just as frightening. And so I think we all have to take this opportunity very serious to capture these patients in this setting. And even in a decentralized model, if they've got evidence of emphysema, we should be bringing them in and conducting a thorough exam and getting them off to PFTs. I know that has implications on workforce and capacity, et cetera, but I think we have a duty to act.
You know, what, Vicky?
Oh, right, wow. So I think we also have a duty to educate, you know, if for ancillary findings to be taken seriously, it's not just an opportunity to educate upfront about lung cancer screening, the risk and benefits. Part of that is you're going to find some ancillary findings. Now we have a responsibility to educate post-exam on these ancillary findings. What's clinically significant, what is not, and that the organization I was at, you know, we were able to, if there was something clinically significant, you would get your aortic aneurysms, your pulmonary fibrosis, breast calcifications, esophageal thickening, and you know, there's quite a few of them. We would actually educate those patients with those results to help them understand which results require further follow-up versus which findings aren't clinically significant and nothing they need to be losing sleep over, to help them empower themselves with some knowledge. So I feel like if we're going to be doing lung cancer screening, an element of that is the education that goes along with what those results are.
Great. Now, I know that John and Ethan are going to be able to say something. I'll hold off, but I want you to be thinking about this, how we're going to be using the reports to be able to help with educating patients as well. I think you're going to be able to touch on that in some of your slides. I think this is a really wonderful area that's developing. One last question, well, not last, but one additional question directly to Minal. And it's about getting all these results. You know, primary care physicians are a burdened group. I hear all the time about, you know, how little time they have to spend with patients. I've heard primary care physicians say to me, you know, another nodule with a 3-month follow-up, you know, I can't keep up with this, you know, that sort of thing. And now we're going to be reporting osteoporosis, where we're going to be saying it's as good as a DEXA scan, do something. And all of a sudden you can get a report and there's going to be 5 different things to follow up on, 6 different things. Is this a good thing? Is this something you're looking forward to? Is it overwhelming you? I mean, right now you're kind of looking at the results, but you're not taking them too seriously. but you will. Eventually, these are going to start getting more and more potent for you. So just thoughts about physician burnout, that sort of thing.
It will add many new layers of work for PCPs. And I think that Joelle made a great point about the centralized versus decentralized lung cancer screening programs and what role they have to play. And I think there's also, I know we're going to be talking more about the reporting, but I think that that's a really interesting place to educate on potential next steps. And now with patients being able to see every single report and every note in their electronic medical record, that's a great way that we are also not only communicating with members of the healthcare team, but also with patients through those reports. So yes, it will absolutely be an additional amount of work that PCPs might, throw their hands up and say, I can't do it all. But there are lots of ways to address the additional findings and additional steps that ultimately are in the service of improving the health of our patients, that won't strictly rely on PCP's efforts of putting in referrals and et cetera. So I think that the challenge will be to systematically think about, distributing that work and using a variety of technologies to address that.
I want to follow that up with, I was sort of bring up the issue of overwhelming clinicians. Joelle and Vicki, you both kind of run programs. I mean, and it can get overwhelming, the amount of findings you have to follow up on. Is there burnout in nurse practitioners? Is there burnout in coordinators? The clinicians only get their patients referred back to them. The nurse practitioners in a screening program, in a sense, are following everybody when they're involved. So talk about that.
Yeah, I'm glad that we're segueing down this path because building again on points that Manal brought up. When we think about the burden of patient care across any care continuum, and today we're talking about this care continuum, I think that number one, we need to think about the opportunity of multidisciplinary teams as the direction that we really need to go if we're going to make headway in this space. This can't land, nor should it land solely on an individual primary care provider who's carrying a patient panel of anywhere from 4 to 8 to 10,000 patients, depending on where they work and what that structure looks like. We need to really be thinking about truly, sincerely driving people's professional practice to the absolute hilt and thoughtfully building teams to really call on what those people are professionally prepared to do. And, when you talk about burnout, you're talking about burnout for a lot of reasons that also leads to a very poor job satisfaction for everyone. If as a nurse practitioner, I'm not being utilized, or as a nurse, my skill sets aren't being utilized to the max, I'm going to feel underutilized and very dissatisfied. Meanwhile, you've got physicians who are very qualified to do many different things, including leading teams, and many disciplines under the roof, who are capable of leading, engaging in science as teams, and really delivering a coordinated effort to support these patients. And so, there are ways to really kind of disseminate that workload that can be very thoughtful, and the patient satisfaction goes up when you do that as well. But I think that we can be more thoughtful about implementation of lung cancer screening and management of those results, where it's a win-win all around, and it can still be very affordable.
Thank you. Yeah.
I have some thoughts on this. Yeah, so I have seen quite a bit of burnout, but where it comes from, and I've seen it both in the coordinator side of screening and on the nurse practitioner side, managing results. And it's not from the excessive number of ancillary findings and trying to manage that. It comes from, one, not having the autonomy within their role to be able to do things they need to do. And two, it boils down to a lot of it is poor workflow practices. And what I mean by that is on the nurse practitioner side, I've seen systems where they set up systems where a nurse practitioner is expected to call every single patient with all of the results. And if you have a limited number of patients that you're screening, then that might work fine. But for a center that's screening 800 or 1,000 patients a month, that's not practical. And not everyone has the resources to hire multiple nurse practitioners. So in those scenarios, what I have found when they've kind of adopted new workflows where they let maybe a coordinator or someone else or do direct sends for lung grads 1-2s or 1-2s and 3s, and then utilize a nurse practitioner for those clinical cases, for those lung grads 4s, or for those ancillary findings that do need diagnostic workup, and let that nurse practitioner work at within their skill set level. It minimizes that burnout. And then on the coordinator side, a lot of that has to do with just a lot of it workflow and not the lack of autonomy that they need to be able to manage those patients. And an example of that would be one of the things that we get a lot is, or what I would hear a lot is, you get patients that are past due, and then these coordinators are trying to chase down orders, reaching out to primary care doctor offices. And so therefore they just get exhausted and they get burnt out on it.
Okay. I wanted to ask a little bit of a follow-up question. How do you think physicians take to the idea of somebody else telling their patients about the findings? So, let's say you sent a patient and Joelle or Vicky's told them, by the way, you have osteoporosis and here's some information on it, and you really should get treated for this, or whatever. You can imagine different cardiac scenarios. How do you think clinicians take to the idea? Because a lot of times, sure, the clinicians that refer a lot of patients will get used to the idea that, hey, this program is doing that. But there's a lot of physicians that are, they only have a couple of their patients get sent. And it may be unexpected if the nurse practitioner sort of gets involved. Do you think that'll be viewed positively, negatively? Depends on the clinician. Any thoughts on that? And Joelle, you have experience with this, so I'm sure you'll have something. And Vicky too.
To me, it's how it's rolled out. I think how you roll it out and then building credibility with those particular providers and building trust where they know, and then keeping your program very simple. They know that their patients are going to be taken care of. Within our program, it was very defined. If it had anything to do with nodules, we managed those in the lung screening program. Anything external to nodules, we would refer back to primary care, but that was communicated thoroughly. And then we also would work very closely in communicating those results and demonstrated appreciation. So there was always coordination of care of those patients. So I found our primary care doctors really respected that, and it was well received, but I know that may not always be the case in other centers.
Joelle, did you have any experience with that? And especially, let me amplify it a little bit more. I think you in particular went even a little bit beyond just the screening findings. For example, I know that you were talking about claudication. That's not a screening finding, as best I know, and yet that became a big topic for you.
Yeah, thank you. And I do want to hear what Manal has to say around sort of that shared responsibility for patients and how that can be optimized and what that experience looks like. Bear in mind, the program that I ran was an absolutely comprehensive tobacco-related diseases and lung cancer screening program. And so the point of that was to really capture this opportunity to identify patients and their disease. And people were shocked when I asked them to take their shoes and socks off, by the way. People aren't accustomed to that. The whole point was to do a head-to-toe evaluation of people identifying risks and symptomatology and intervening on things that were very focused on what could be induced by tobacco. And I will say that that program was very focused on collaborative effort with primary care providers, and it became just a really great partnership with PCPs. So PCPs, I think, really saw this program as an extension of their care. And you know, there was a defined line though of what I would do and then what I would hand back off to primary care providers, even though I certainly had the scope of practice that I could be prescribing and further counseling patients, but I would do the assessment, you know, counsel the patient, and then make some recommendations for them to take back to their primary care providers. And I also took responsibility for their tobacco cessation as a certified tobacco treatment specialist. So I offered anyone who were currently smoking cessation services that extended past their screening. So I would continue to see them and manage their tobacco use. Manal.
I think that the point of communication and just kind of clear, defined expectations of who's going to manage what and who's going to communicate to the patient, as long as that's there, I think most PCPs I would expect them to really appreciate a team-based approach to managing the findings of lung cancer screening. So, you know, I don't know that we have a survey of a nationally representative sample of PCPs and their thoughts on this, but I would expect that most PCPs would appreciate a team-based approach.
I can tell you now, at Mount Sinai, where we've just installed the DEXA equivalent software to look at for osteoporosis.
Mm-hmm.
There's going to be developed some type of care pathway for what to do with those people that have severe osteoporosis. I mean, people are talking about, and nothing's been decided yet, but should these patients get directly referred to an endocrinologist, like almost automatically? Things like that are starting to be talked about. So I think there's going to be a real, as these findings get better and better defined and we understand them better, I think institutions are going to have to start figuring out how they want to handle it, because some institutions will have nurse practitioners that will get sort of in the middle between the clinician, and I think there's going to be a lot of sense of, whose patient is it? Does it become part of, the institution is going to start having a sense of ownership and saying, hey, this goes, this follows this care pathway automatically. I think that all of these things are going to start opening up, and it's also going to, like, a lot of the educational issues are going to start coming in. Before I go for Bruce, were there any chat questions that were burning?
Nothing burning yet.
Okay, nothing burning. Good. I wanted to just follow up a little bit more with the nurse practitioner and the study coordinator. Who do you report to when you're the nurse practitioners? Do you just report to? I'm going to say report to you have a clinician that you're working with. In our screening program, for example, we have several nurse practitioners. They do all the shared decision making. They follow up with some of the patients, but they can be very, very reluctant to take on a deeper role in terms of things like osteoporosis and getting into that level. And in large part because they don't want the responsibility, and especially they don't want the responsibility when they're working for a radiologist or they're working in a radiologist's office. They want to report to somebody with more primary care expertise. So I'm curious how that's being handled in other places, because other people are going to have this responsibility. And so how does that work?
Well, I have a lot of thoughts about that.
I suspected you might.
I train nurse practitioners for a living, in another part of my life. And I've been an NP for pushing 30 years, and we've seen practice really evolve over time. And anyone who knows me knows that I strongly encourage everyone to work at the top of their scope of practice. And if you don't use it, you'll lose it. And I will also say that nurse practitioners initially need some strong mentorship to build the confidence that you're talking about to actually harness these areas of practice where they feel confident that they can safely and responsibly care for people and manage their problems, diagnose and treat. Scope of practice does vary across the US. There's nearly 30 states in this country now where nurse practitioners have full scope of practice. I could go start my own practice if I wanted to and be completely independent. The level of autonomy that nurse practitioners have and the scope of what they do within the context of the care delivery area that they have been hired to do really depends on how that's been designed. My experience in the field, particularly with volumes of students who have then gone on into practice or who are in training and witnessing these areas and the practice of those who are precepting them, is that there's wild variation. And on the whole, nurse practitioners are being highly underutilized. And the bummer is if nurse practitioners get into a role like that, it does take a big leap to get them out of that role that tends to be more limiting into a more independent role where they have more responsibility. And I don't take that responsibility lightly. And I think it's really important for people to know what they don't know, and I always encourage having strong mentorship and connections, whether it's pharmacists or other specialists to be able to call on. So they need to really have themselves positioned to be successful. I will say I agree with Vicky's observations in the field. Job satisfaction and burnout it's very common in people who are not being utilized and who don't enjoy some autonomy in their practice. And I would caution health systems and supervising physicians or physician mentors and leaders and health administrators. I would really caution them to in limiting nurse practitioners and how they function in teams. We should be absolutely exercising what they have to offer and finding ways to help them develop the skills, because otherwise it's just a waste. It's a waste of a professional, a skilled professional, and it's a waste of dollars and utilization that could really be of great utility, especially in this setting that we're talking about today.
Okay, I wanted to change gears a little bit and give John and Ethan, they have some slides to show, and then we'll continue the discussion based somewhat on what they have. You can see they have an interesting office space.
Whoa.
Go.
Thank you, David. First I have to apologize. I woke up this morning with no voice. It's slowly coming back, but if it goes away, I'm gonna have to hand the entirety of this over to Ethan. Why don't you start sharing that? Yep. All right, so we've been doing some research on behalf of Paraxial. For those of you who know Rick Avila, that's he runs that, and he's the one who set us out on this project to see if there were any applicable ways to use artificial intelligence to help with having radiology reports be readable by lay people. And we understand that no one here are computer scientists except for the two of us. So we're going to give like a real 10,000-foot view. There's a lot going on under the hood, but and we'll answer any questions in detail, but I doubt that's where your questions will be. So to give you a concept of what a generative large language model is, that's what ChatGPT is, which is what everybody pretty much knows what ChatGPT is now. You feed in some text and it spits back some sort of response. And that's the same kind of format that we've been working on to uh, to utilize uh, this technology to convert radiology reports. The next one. You want to hit these?
Um, yeah, so there's 6 main categories that we've been focusing for what we want in our outputs, which is I'd say the 2 most important are not hallucinating and not omitting any important information, which yeah, a hallucination would be I'm sure a lot more people now are kind of familiar with this with models like ChatGPT, where you'll ask a large language model a question and then it'll completely make something up. We've actually had really good luck with that, and as we progress, we've gotten practically no hallucinations. Some of our more recent generations, but that's always a concern. And one of the more difficult ones that we actually have been getting pretty good progress on as well is empathy, where we really don't want the message to sound robotic. So it's about just using as much sympathetic language as possible in appropriate amounts, and generally just how a person would say it. Understandability is uh, a big one as well. Most of these are, but that's like a lot of the terms that are in the reports that we're feeding to it have a lot of words that most people wouldn't really understand if they don't have a medical background. So we need to kind of hit a balance between giving the information needed without requiring a medical background to actually understand what it's telling you. And then fifth is just additional information, just anything commonly discussed with a patient that could be automatically conveyed with the report. And the sixth is something that's kind of independent of these, which is translations, where we've been trying to, in order to expand the scope of the project, see if we can get the generations to officially translate into other languages using AI, which it's for languages like French and Spanish, it seems to be working quite well, but we've tried like dialects of like Ethiopian languages and such, like where there's not as many resources online, where it has just said the same word over and over again. So we're working on trying to train it on more specialized languages.
Okay, so our goal was originally to see if this is a viable option, and it actually does appear to be. I know that you can't really see this. You can kind of get an idea. I mean, maybe some of you can read that, but on the left is it's just a anonymized radiology report, and we fed it in through a large language model with given instructions, and it comes out with what's on the right. And this is an actual result that's in front of you. Um, and not that you need to read it or anything, but the point of this is that this is viable. Anything that it may have problems with now, it can be trained to not have them in the future if enough resources are put into it.
So as far as empathy goes, we've got 2 examples here for good news and bad news, which is really the main distinction that we've been focusing on recently, since getting it to give a level of empathy is a lot simpler. Which for good news, the example, if you can't read it, just starts with I hope this message finds you well. I'm writing to share the results of your recent CT scan, which was conducted on the date, and then it just continues kind of quicker in. And then for bad news, it kind of has more of a preface of like, I understand that receiving medical information can be overwhelming, but I want to reassure you that we are committed to your care and will be with you every step of the way. If you notice any new or concerning symptoms between now and your follow-up appointment, please do not hesitate to contact us immediately. So we've so that kind of adds that extra layer of uh going between good and bad and trying to make it so that people with good news don't read their introductions and panic and be like, oh no, is it something bad? And that people with bad news don't just kind of get some really bad news just dropped on them dryly.
And just to be clear on that last slide, those generations were actually large language model generations. Those weren't human written.
Yeah.
And now and then, Ethan touched on this in his first slide. There is a huge spectrum for a patient with their level of understanding. They can be, very, very educated in, different medical fields. They can have absolutely no concept of anything. So there needs to be either a way to scale it, but more likely what you're going to have, what we'd have to do in the future is just set it so that there's a current baseline, because you don't want to have to set it and have to judge your patient's ability to understand. That really shouldn't be on the doctor. So this is another area that we've been working on.
So it's just elaborating more on the translations. The goal is to eventually have this available in practically any language you can think of. As I said before, if you're trying to translate into German, French, Spanish, then there's really not going to be too many problems. There's going to be a lot of resources online that are telling the model what to do. But part of our kind of more extended training of the model is going to be in focusing more kind of like smaller scale languages, and particularly the challenge comes with languages that are in less developed areas, because of course there's like fewer resources giving context to those languages on the internet, since less developed, less internet presence.
And that's the 10,000-foot view. So we imagine that questions are, probably going to be all over the place. So we're ready to field them.
Okay. Thank you for that presentation. I have to also say that this is an open source project that Rick is leading.
That's correct.
Which I think is really terrific. I'm going to take the moderator's prerogative and ask the panelists for their questions, starting with Minal. How do you feel about the idea of these kind of reports being generated? Do you have thoughts about how they might be used, et cetera?
Well, I received two messages this morning from two different patients. So one was a patient who got a CT of their abdomen and pelvis, and it showed a simple renal cyst. And it was ordered by someone else, but they wanted to put it on my radar, and they said, I just want you to know, let me know if I need to do anything else. And so it was never communicated to them that, this is a sub-centimeter simple renal cyst. There's nothing more to be done, because it wasn't a part of the, impression, even though they, it was in the report and they saw that. And another was a patient who had a mammogram and had or breast artery calcifications. And she said, I was told I should talk to you about this and what's next to be done. So these are the two examples that are just from this morning, that I think highlight that there's so much that we should be exploring in terms of how radiological reports can be better communicated to patients, and even potentially with guideline-based or evidence-based next steps, that would be so helpful to their care overall. So I'm very curious to know how this could be potentially implemented and what the consequences would be for patients and care overall, and how it either improves, guideline concordant care versus not.
Before you comment, John, I'm just going to say that our friends at the FDA who are regulating or looking into this natural language processing will be able to comment on this in the next session. Go ahead, John. Sorry.
It's actually great that you brought that up, because that's something that we have worked on but have not put into the slideshow. Defaultly, these generations do give patient instructions on follow-ups, how often they should go back to get another scan. It's based on what, the report, it can either be based on what the report says or what's commonly done if it's trained to know that. So it can go further than, it actually is quite customizable. It takes time to train these things. They have to have a lot of data, and they have to be able to go through different ways and then get the right result over and over again for it to know what it's actually like, this is what I'm supposed to do with it. But yeah, that is definitely something that we can do with large language models.
And you've
Well-
explored, including the part of the training, the kind of guideline recommendations for, X, Y, or Z.
So we're actually using, we start this with open source language models that are already available to the public, and you'd be shocked that they don't even really need training in most of that, because they are trained on such huge data sets from all different things that, I've heard there's like some certain codes that are on some of these reports. It knows what they all mean by default.
Do we have any more questions from Vicky and Joelle?
Yeah, I think I'm building on what Manal was kind of pointing out, which is, I think this is beautiful technology, and I applaud you on the work that you're doing, and look forward to seeing this continue to develop to help us in our jobs and ease our workloads. That said, I think, and maybe I'm just showing my age here, but there's some friction in my own mind around how we incorporate really important care pathways and information that, using the example of the simple renal cyst, there's a higher level of clinical decision making and expertise that has to come to the table, including some nuances of what might be reported in that imaging report. Like, is there a Hounsfield a score that is reported about that the characteristics of that renal cyst, and the size thresholds, and what the current guidelines tell us around management and required follow-up. And I think I would feel very hesitant to just release that. And also the way I counsel my patients about what their risk is, and one thing that I think that this program probably doesn't have information about is the patient's medical history, and maybe even their family history, and how those risks need to be situated within the counseling to the patient and the follow-up recommendations. So those are the kinds of things that come to light for me when I am thinking through sort of the utility and the viability of leveraging this kind of machine, if you will, in my work.
John and Ethan, you can respond to this, and this is going to be sort of the last response because we're already a little over time. So please give us.
Okay, I'll try to keep it brief. Yeah, so this is a developing technology. They're going to get better over time. And your concern about taking a computer generated report and just releasing it to a patient, that is a very, 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 there's a lot of potential there for a disaster. The intent is for these, originally in the infancy of these programs, to have it signed off on by the whomever put the report together, so that it doesn't go out into the wild with incorrect information or missing information, or bad follow-up instructions. And as you said, there's a higher level of decision making that goes into it than you can trust this to. That can all be worked into in the future, a means of conveying that to the model and having it restructure it in the form of a report like this.
Okay, well, that's all the time we have for this. I want to thank the panelists for this, I think, terrific discussion. So, great. Okay, so we're going to start the next session. And the next session is software approval and reimbursement impact on utilization. Topic overview will be given by Morteza Nagavi, and we have panelists Bruce Hyanson, Kyle Myers, and Robert Oates, who will all introduce themselves when it comes. But first, let's start with the topic overview by Morteza Nagavi, who is pretty well known to this group. But please, Mort, introduce yourself first. and then let's have the overview. Without slides, I understand.
Good afternoon to everyone. This is Morteza Nagavi. I'm a physician by training and a technologist by passion, medical technologist. I don't have a slide set to share with you, and I'll be happy to answer questions or follow our chairman's lead. But he basically told me that he would like to elaborate on where AI-enabled tools can come to preventive care, in particular cardiovascular and lung cancer screening, under the umbrella of chest CT, ideally low-dose chest CT. There are a few companies that have brought solutions to patient care. These companies primarily focused on either lung nodule or coronary artery calcium score. These two are the two primary characteristics of the two diseases. Number one, killer cardiovascular disease. Number two, killer lung cancer. In cardiovascular disease, if you look at the entire sphere of preventive cardiology, atherosclerotic related diseases account for about 60–70%, depending on the age population. And then we have heart failure, which is also affected by atherosclerosis, but could be also independent of atherosclerosis due to valve and hypertensive disorders. And then muscle-related valves and atrial fibrillation in a stroke. So there's a big umbrella. Coronary artery calcium is just focused on coronary part of it. Our group, what we refer to as AI-CVD investigators, are trying to bring as much value as possible to the same scan that the patient paid the radiation cost for, and the health system allocated the resources. So there's a ton of information, actionable information, as you can see in the image behind me. We are working with our co-investigators towards the FDA clearance of these modules. But at the end, it all comes down, as you all know very well, whoever has practiced medicine in this country, it all comes down who pays for it. If we force our patients to pay for it, we're going to be very much underutilized, and we're not going to make the impact. If the healthcare system that is paying $3,000 for a stent, or $25,000 for a cabbage, and $5,000 or $3,000 to $5,000 for a PET CT for secondary and tertiary prevention, which literally affects 20% of life expectancy. The rest of it, which is primary prevention, gets the very tiny fraction of our healthcare budget. If we continue on the same path, we're just going to get the same thing that we've had over the past 50, 70 years, which is increasing burden of cardiovascular disease, increasing burden of lung cancer, and not really reducing preventable deaths. So I'll stop here, David. If you want me to specifically answer a particular question, I'm happy to.
No, I think we'll let the panel members see if they have any questions. But first, let the panelists introduce themselves. Bruce?
Good afternoon, Bruce Pyenson. I'm a actuary that's worked across industries in healthcare for 40 years, and recently served on MedPAC, the Medicare Payment Advisory Commission, an agency of the U.S. Congress. Thanks, David.
Sure. Kyle?
Good afternoon, I'm Kyle Myers. I'm an imaging physicist, and I spent almost 35 years at the Center for Devices and Radiological Health at FDA, where I led the research program in imaging and diagnostics that supported what we're going to hear about from Robert Oakes in terms of approaches for evaluating medical imaging hardware and software devices.
And Robert?
Yeah, good afternoon. Robert Oakes from FDA. Kyle Myers is on the research side. I is more on the regulatory side, and I'm in the radiological health program. So in my office, we review the new imaging technologies for radiology, imaging software. We also do therapy, but more applicable to this group is the imaging software, quantitative imaging software, as well as the imaging hardware. So thank you for inviting me.
Okay, so we'll start off. I want to start off. We're going to do this the same way we ran the last session. I'll have questions sort of targeted to a particular person, but all of the panelists can sort of chime in, and more, you're welcome to comment as well. So starting off with Bruce, how does Medicare decide reimbursements? I know this is a pretty broad, but in particular, I wanted to look at, because we're in the lung screening world. There's two that I found particularly interesting. Optellum and Biodesics get reimbursed for evaluating indeterminate pulmonary nodules, and they get reimbursed 3 to 4 times the cost of the scan itself. How does that work?
Well, let me say I don't have knowledge of how those decisions were made. Not for lack of trying. I have no particular connection or involvement with those. I can talk, if it's useful, more generally about some of the things I've seen in other categories and other services pricing, if that's useful. And I think to start, the Medicare program has a lot of rules that it has to follow about setting prices, and in general, they're responsible for budgets, and they're also have a view of supporting new technology and new innovations with sufficient funding to get them going. And on that issue, there's some programs such as the New Technology Add-on, or for dialysis patients, TDAPA for new drugs. And those are temporary programs with extra payments with the view of allowing CMS to collect data on their use and to encourage adoption. And after a while, typically those payments are integrated into the standard structures that Medicare uses to pay. So my view is that high payments that seem high are probably temporary. I'd also comment that within the physician fee schedule, the extra payments going to certain items are arguably over the course of the budget, compensated by lower payments throughout the physician fee schedule. So those I think are dynamics to keep in mind. Just to editorialize a minute, I think there is, of course, a gold rush by entrepreneurs seeking rents from things that cost almost nothing to develop, but will generate a large stream of payments for a long time, and that's just bad for everybody. So I think the goal of software and new technology should be that they're going to add efficiencies to the system and reduce spending and not increase spending. that hasn't been the case. But that's my editorial, and that was my view when I served as commissioner on MedPAC.
Yeah, I mentioned the two indeterminate nodules. There's a couple of them also in the cardiac domain. Mark, can you comment on that?
Can I start by just adding to Bruce's editorial? I'm not aware of any entrepreneur who can develop something at nearly no cost. They go through a ton of cost to develop it. But you're right about once you have a software, just like Google or ChatGPT or other places, the cost of rendering that service is, for example, in case of heart flow or Clearly, could be significantly less than any other things that are done in the on the ticket. They charge a significant amount, but even that, you look at these companies, both are losing money. So there's something wrong with our entire system when we'll look back from a patient healthcare, public health point.
I agree, and I didn't mean to diminish the blood, sweat, and tears that entrepreneurs put in, but just to contrast the what I've seen of that to the hundreds of millions and billions of dollars that are being spent on developing, new medical centers and the atria that you walk through to get to the radiology departments, in the scope of the trillions we're spending in healthcare.
Sure. If we could agree as panel members and all participants in this meeting, is that we have a very fundamental problem. Our very fundamental problem is our focus is only on the symptomatic part of healthcare. That's like 80% of our budget, maybe 90% of it. In cardiovascular disease, 95% of our budget is spent on that part. And that once a patient is symptomatic, we only have a very narrow window of opportunity to improve life expectancy, to improve mortality, prevent deaths. We just delay it a few months or years, and then at the cost of poor quality of life. That's the fundamental problem. So I lived and made most of my success, commercial, is from secondary and tertiary prevention, developing catheters, devices that are intracoronary and add very little to outcomes, but make very good money. That's our fundamental problem. And unfortunately, I don't see any movement in Medicare, CMS, those policymakers to reset this, even though, pay for service was a positive move to the right direction. But we have this fundamental difference in attention to primary prevention, preventing the first heart attack, preventing the first symptoms versus preventing the recurring heart attacks, recurring syndrome. So if we could take this message out to healthcare policymakers, put more money right now, though it doesn't pay next month, it doesn't pay probably next year, maybe next 5 to 10 years, but it's the right move to do, and that's what's missing. So as you know, we've been trying to communicate with CMS for now 6 years to get calcium score coverage for like $100. And they've been along the way covering all kinds of things in interventional cardiology, in surgical implementation of new tools, devices that entrepreneurs like me make gazillion money. That's where our problem is. And I hope part of this meeting and the conference we had in New York Academy of Medicine with David and Claudia and others, hopefully we can bring that attention to healthcare policies with the help from economists and healthcare economists, brains like Bruce. David?
Yeah. Well, we'll keep working on that more, that's for sure. And I appreciate your point about the need to switch, the need to move more and more towards preventive health. And I think I dream of that revolution really starting now, and to a large extent, that's going to be driven by Medicare and FDA in terms of the products they approve and how it, you know, gets reimbursed, et cetera. That's going to really help drive everything. I want to just bring out something that's come up because it was what I was talking about earlier. There's always been sort of two major models for reimbursement. It used to be you built a software product, you sold the software product, somebody bought it, and then they used it at will. You didn't, and now the model is much different. Now the model is the company that sells it gets a per click fee, a service agreement, and that seems to be the dominant model. Bruce, you were talking about that it goes even privately. You were talking to me about it, but this goes even beyond medical devices. It's everywhere now in software development.
Well, I'd say it's everywhere in the enterprises that we're seeing. A friend of mine bought a new car, and in order to have the garage door opener work, she would have to pay a monthly fee to a software company. And this is also the case with the different manufacturer if they want
They
their
charge each time she opened the door, though?
If you want the seat heaters to work, you pay a license fee that a switch gets turned on. So this is the move to a rent-based economy, and I blame what's called neoliberal economics for that. So that's I think akin to what Mort was addressing as, you know, the prevention and the primary source would be a much better way to go.
Okay, let me switch gears a little bit and ask a question. And we'll start with you, Bruce, but I think this will start moving towards our friends at FDA. By what process does Medicare reassess approvals for payments? Do they have a process, or do they simply rely on FDA approving a product and that's it?
Just because the FDA approves a product is not sufficient for the Medicare program, and the Medicare program by statute is can only pay for things that are it deems are useful for the treatment or diagnosis of conditions, and in particular takes account of the population characteristics of the Medicare population, mostly older people. So some of FDA's criteria for approving things, has been controversial, and the approval of Leqembi for Alzheimer's, for example, which is controversial in terms of does it really do more harm than good. So I don't think it's not automatic, and I think there's always a role for to separate in my opinion, to separate the license and approval from the payment. They're different things.
And how do they, but I'm trying to drive, once it's approved, how does Medicare continue to approve? Do they continue to do their own evaluations? Do they say, okay, we approved it now, and now we're just going to play around with how much we're paying? We're paying a lot now, and over time, we lower the amount we reimburse. Well, how do they? Those
are two different things, and there's what's called coverage determinations, and there's a staff of people who do that, and so there's different processes and different rules for different kinds of things and timelines and so forth. The actual payment structure falls into different categories. If it falls into the physician payment, physician fee schedule or physician payment system, whether it falls into the inpatient prospective payment system, the outpatient prospective payment system. There's different rules, and in general, Medicare tries to keep things consistent as new technology comes in or as old technology leaves. To, you know, they have thousands of codes that are priced, and how does this fit relative to other things?
What I was trying to drive at, once something is approved, how do they stop approving? Is there sort of a process? They say this is no longer effective. Where do they do this? Is all an internal evaluation, or is this something where there's a routine that they continually reassess the value or the usefulness of it?
Yeah, I don't know the procedures for that, so I really can't talk to that.
This leads a little bit into, and you'll have more chance in terms of FDA, how they reassess once they've approved something. So software is approved. And I know this is a huge topic, so maybe just touch on it now. But once a product's approved, how does it stay approved? Does it, if you get new information, how often do you look at new information to say it should continue to be approved? New technology advances, does it still, you know, CT scanners get better and better. Does it still work the same way on the software which is developed with older technology? I know this is a huge topic. I just wanted you to sort of briefly, Kyle and Robert, to comment on that.
Sure, yeah, hopefully you can hear me, and
Yes.
my video is working. Yeah, my took a little bit of a risk. This is, I think, the first time using Zoom on my new computer, so a little bit of bugs here and there. But yes, once a product is authorized by FDA, it generally remains authorized. The actual process for FDA to withdraw or rescind an authorization is rather complex and extremely rare to do. There are a few instances, and I think ones that came to my mind were where the device was authorized and there's underlying concerns with fraud in the data underlying the authorization. So in general, a device remains authorized by FDA. There's not a requirement for a device to come back every 3 years to, you know, show it's still as safe and effective as its initial authorization. But that said, manufacturers do have requirements under good manufacturing processes, quality systems that apply. There are also some, in some case-by-case circumstances, FDA may require post-market studies. For some AI systems now, we've also added requirements related to sponsors need to have post-market monitoring plans for those AI systems to kind of answer some of the questions you raise. You know, the FDA review and authorization can sometimes be quite narrow. It can't answer all the questions out there, you know, because it'd just be overly burdensome. So, you know, FDA authorization may occur based on data collected at a specific period of time with a certain set of, you know, scanners or manufacturers. But, you know, those scanners and manufacturers may be upgraded, they may change over time. So yeah, it is a hot topic of how do we know that the software continues to be safe and effective. There are some things in place, but it is a hot topic to think, well, should we rethink about this, especially in the age of AI? And how can we do it to have a greater assurance of the continued safety and effectiveness of FDA authorized devices?
Kyle, do you want to add to that?
I just wanted to, you know, reiterate some of what Robert said, that most imaging device software is clear. He's being really careful in a great way, talking about authorization that puts together both 510(k) devices, which are shown to be substantially equivalent, and sometimes things that kind of go pretty far back historically. And in order for us to know how that software works in modern times with data yet to be seen by the software at the point of authorization, FDA, you know, is making use more and more of additional ways to collect data going forward without being burdensome on manufacturers in terms of what's expected at the point of FDA decision making. And I think that's been something that FDA has taken some criticism for in the literature around not doing prospective studies for imaging software, but we have maintained that that is a good place to be in terms of a sufficient evidence to make authorization, FDA decisions while allowing for devices that have been shown to either be substantially equivalent to what's already on the market, or in the case of PMA products, devices that are shown to have benefits outweigh the risks in a way that are, make that balance at a reasonable price point or burden effort on the part of manufacturers.
I was struck, I bring this up because it's just a particular example that I was aware of, and that is a particular CT scanner, which had applied for specifically to be approved for lung cancer screening, got FDA approval for that. It turns out that we found that scanner has a particular issue with spatial warping. And so if you're trying to measure things accurately, it probably doesn't do it very well. Now, this wasn't known for a long time, and it was after the NLST actually had come out with its results. Now, it was used in the NLST as one of the more common scanners, and NLST had a wonderful result, and I think on that basis, it was approved. Now there's this new information that, hey, maybe it doesn't measure things as well as we hoped. And if you're going to be doing lung nodule volumetrics for lung nodules, you could have a pretty serious problem here. Is there a mechanism, for example, does FDA even have a mechanism where they'd say, hey, we heard this, we want you, company X, to give us new information that it could be used, or have you developed a fix for this or something? Or is this just not something FDA really has the resources to do?
No, we do have multiple post-market requirements that could apply in a situation like this, or could feed into action by FDA or a company. So we could get what's called medical device adverse event reports, potentially. I had to think a little bit of how it might apply in this situation. But we do have a surveillance system where we tend to get reports. It's not perfect, and we'd like it, to be a little bit better. But if reports are coming in that there's measurement errors with this system, we do have the ability to reach out to a company and say, hey, we're getting these reports. Are you receiving these reports? What's your analysis of this? We can also go out and inspect. I mean, if a company comes back and says, nope, haven't seen anything, we can send an inspector out to the company and be like, how about you show us any emails you received in this date and time? Let's look and see what you have here. And, what it could lead to, or what it feeds into, is, requirements in our quality systems to have complaint handling processes, or processes to take in information and decide, is this something that is actionable and needs to be addressed? And the way it could be addressed could be through a recall. A recall doesn't always mean, oh, you're going to, pull the CT scanner out of a hospital. It could mean there needs to be a software update to perhaps address an issue with how the image is displayed, or the warping, or maybe it's something that can't be fixed. And it just has to be, there needs to be a notification, or there needs to be something so that facilities know, oh, actually under this mode or in this protocol, there's going to be potentially a measurement error. So there's a lot of risk-benefit decision-making that occurs during this, trying to understand what are the conditions where a failure might occur. But there definitely are mechanisms that can be used to address, these situations. In general, if it's something that requires a fix, it'd be under our recall authorities.
Robert, I'd love to hear you speak more to this. We know that the devices, the CT imaging devices that were used in NLST were shown to be fit for purpose for lung cancer diagnosis, and that's why they were able to have that labeling be added to the FDA labeling indications for use once the NLST data was out. That trial didn't involve a measurement methodology. And I think what David is speaking to is the awareness on the part of researchers and software developers, that they're able to make measurements more accurately with some CT data sets than others from some manufacturers. But the manufacturers haven't made claims that measurements to a certain precision can be made. So I think it falls a little bit in the gray space, doesn't it, in terms of whether that's their responsibility or part of it.
Yeah, and that gets to kind of the challenges sometimes we have in the imaging space. You know, we've cleared imaging CT scanners, really they're cleared to do general whole body imaging. You know, it'd be, I think, overly burdensome to, I guess I'll share my opinion, to require a new CT scanning manufacturer to run a clinical trial for every single protocol that they want to use on that scanner, or every single, you know, measurement they want to be done or claim to be done. It just becomes unduly burdensome. But yeah, we really, you know, want to try and find this balance of allowing innovations in CT scanner technology. We don't want one new CT scanner to come out every 20 years because of this requirement. But we also need to make sure we have the safeguards in place so that people know, oh, if they're seeing issues with this measurement, you know, they know how to report it to the manufacturers, who then should be investigating and see, oh, is this a reproducible thing? Is this something that we need to fix? Is it a bug in the software that we can fix? Or is it something that can't be fixed and we just need to make sure users are aware of it? Or is there something else that can be done? So it's really, you know, kind of challenging sometimes to get the balance right. But as Kyle said, yeah, the CT manufacturers, when they came in, it may have been, I'm doing whole body imaging or I'm doing a low dose protocol. You know, we saw LNOC was done. You know, our scanner has the same, you know, technical parameters, can do the same protocol as an LST. Can we get this on label? And generally that was considered acceptable. But some of the more specific uses of, we can measure this with that level of accuracy, they might not have said it. So now you end up in a space of other people saying, oh, actually, maybe it's not quite as accurate as another one. Is it still okay or is it not okay?
I just wanted to also wave the flag for the FDA participants in the quantitative imaging you know, research environment through KIBA and this organization that really helped to inform the quantitative imaging guidance that is out now, and it communicates to folks what FDA is looking for in terms of making quantitative claims. How you do that, what kind of evidence is required. And that's a pretty recent development, right, Robert? It came out just last year.
Yeah, time flies. It is recent. Definitely probably in the last 5 years, in the last year or two. But yeah, sometimes time flies a little bit. But there's that guidance out. You know, there's, you know, on the FDA list of guidance that they want to be published. You know, it also talks about guidances related to AI and you know, also do a plug. I don't want to hog up the whole time, but you know, I know there's a, you know, a great talk earlier about use of large language models. I'll just say, you know, FDA is actually holding a meeting, a digital health steering committee meeting next week related to the use of generative AI. So again, another very complex topic where we're trying to understand, like, where should we be? What will be regulated? What will not be regulated? What should we expect for the software?
Okay, a question circling back again to Bruce. Does Medicare do anything to promote development of software? I mean, is that in their interest? And what mechanisms they have to fund even development of software?
It's not something I've looked at in depth, but certainly there's a range of software that that's part of the healthcare delivery system that's funded through Medicare. And for example, the costs of the hospitals and others have electronic medical system records flows through the Medicare cost reports. So I think it's part of what they know is going on.
Okay. I'm going to move back to FDA a little bit and ask a sort of a question. When FDA is considering approving a product, do they, what's sort of the main drivers? Does it improve interpretation? Does it improve speed of interpretation? All of the above? I mean, how do they decide what's important that a product does?
Yeah, that's a good question. Definitely a lot of time could be spent on this. So I'll try and give a brief overview as I can. But, at first it'll depend on the regulatory pathway, which is based on the risk of the device. High risk device, the requirements and expectations will be a little bit different than a device that is a more moderate risk. And actually for some devices that are very low risk, they don't even have a pre-market authorization requirement. For example, like tongue depressors or something that's a medical device, but it's not going to get FDA reviewed before going on market. But the common factors in the devices that do come to FDA for a pre-market review, it's going to be driven on what is the intended use of the device, the indications for use of the device. Are they, very general? Going back to our CT scanner, is it a CT scanner that's indicated for general body imaging? Or is it a very, very specific indication for use? Maybe a CT manufacturer wants to make a very specific claim, example, like, a new protocol for lung cancer screening. So that will drive our thoughts on what the appropriate level of validation may be for that intended use. Usually there's, multiple different ways to get at adequate validation to demonstrate the safety and effectiveness of the device. You asked about the speed to interpretation. Speed alone typically isn't going to be considered effective. I think we have concerns about effectiveness in the sense of, well, maybe it's faster, but did you lose a lot in diagnostic accuracy because you made it faster? So really it gets tied to, more of a, diagnostic accuracy based metric related to diagnostic products. But we also, think about, again, for the validation, are the tests going to be generalizable? How is it studied? Where is it studied? What technologies are used? This isn't necessarily a deal breaker, but it may inform the next consideration, which is what is the labeling of the device going to be? If the device was only tested on, one set of scanner models and equipment, we may have concerns about allowing the manufacturer to say, oh, our device can be used on any and all scanners and models of equipment. So we may take well, okay, we'll authorize you, but your labeling needs to specify this was the equipment used in our study. Definitely you're welcome to come back and broaden it and get more data on other scanner models to expand your labeling. And we also think about the benefit risks of the device. In some situations, we may accept greater uncertainty in the performance if there could be an overall public health benefit of the device. For example, what may be acceptable for a device that's going to expand access and allow use in a home, by a lay user might be different than what we might expect for something that's intended to provide a definitive diagnosis for a disease or a condition in a hospital. So these are all factors. We also think about risk mitigations, and that, for example, if something's going to be used in the home, probably need to have different risk mitigations, or maybe it has a slightly different intended use as like maybe a preliminary assessment, that could drive someone to go to a hospital compared with being like, oh yeah, this is, medical grade, because it might not be there because you have a lay user using it. So there's definitely a lot of factors that go into the consideration for FDA to authorize a device. We try to be flexible, but again, it can really depend on what is intended by the sponsor for marketing the device.
I guess when I asked the question, I was sort of thinking, why does a clinician want to use the software? Somebody builds a software for lung screening. So if it finds lung nodules that I may have missed, I say, that's really of value. It's going to find something that potentially I wouldn't have seen. But when it comes to something like, let's say osteoporosis scoring, I mean, I could put a cursor inside a vertebral body and say, here's the density. The software is not going to, it doesn't help me so much in terms of making a diagnosis. I can measure all the densities and do that, but it saves me a ton of time. You know what I mean? So it seems like, there's sort of different motivations for using software. One is, I don't want to get sued by missing a potential lung cancer. And the other is, I just don't want to take the time to measure osteoporosis or to put a little circle around each coronary artery calcification and, and find it. So there's sort of these different, now I don't know when they come to you, they're not saying, look, we saved so much time, say the clinician, they do a comparison study for osteoporosis, and it took the software, few seconds to give them versus the radiologist time if he had to measure it, took him, 20 minutes to whatever. But it seems to me that those are some of the things that will make a clinician want to use software. It's not just improving diagnosis, it's the speed of which you can do things that becomes important.
Yeah, absolutely. And I definitely get where the question is coming from. Like I'll use another example. I said, like, breast density off of a mammogram. We have software that can automatically assess breast density. We've authorized it. And it wasn't necessarily that the software is saying, oh, we can be better at assessing breast density. But it's saying, we could reduce reader variability. We can automate this. So, sometimes what is necessary to get FDA authorization, where we're looking at, okay, how effective are you? Are you going to be better or worse than a reader, a radiologist, trained radiologist in doing this assessment, or reduce variation? Those are kind of more metrics that are based on like, accuracy of the software. But when it gets to reimbursement and uptake and utilization, the endpoints for that study, or the endpoints that kind of convince someone, yeah, this adds value, are going to be a little bit different than the endpoints to just, yeah, how's your accuracy compared to an expert user or another piece of software? I mean, they're both important, and both to kind of get this, aim of being FDA authorized and utilized. Sponsors generally do have to think about trying to do studies or do more than one study to address those questions that different stakeholders are going to have about their software and its benefit.
Let me ask a question about a little bit about sort of a relationship between FDA and Medicare. And this is pertinent to the group here. The issue of breakthrough designation, which FDA can give to a software, how does that impact Medicare if software gets breakthrough designation? And can anybody talk about that? Is that something you're familiar with?
I can't talk about that.
Mort or Robert? Is that a topic?
Breakthrough designation doesn't mean it's been approved, so that
No.
CMS doesn't have to.
They don't have to approve it, but it often allows.
It means it speeds it up. Speeds up the review.
David, I can comment here. You, of course, know that we got breakthrough designation from the FDA for what you see right here, cardiac chambers volume reporting from CT scans. And to my knowledge, the prior administration, the first Trump administration, had an automatic reimbursement for, I think, 2 years, I don't know exactly, for a breakthrough designated medical device. So they halted that with Biden's administration, but they put an asterisk that we evaluate and we may provide additional benefit or some kind of value. So they do have a path to assess an FDA cleared breakthrough device for reimbursement. But I have to tell you, in our experience, it's been extremely slow. Just to get the first meeting, we have been waiting for about 2 months. And so that goes against the nature of breakthrough and why FDA put the 90-day fast track or ultra fast track. The FDA did its job. Now, the first meeting takes 2 months just to talk to someone on the other side. At the end of all of these, there are a lot of breakthroughs. Most breakthroughs are not primary prevention. To my knowledge, we're probably the only breakthrough in primary prevention of imaging of cardiovascular. And so it goes back to what I was bringing up, is that we need to really have our colleagues at Medicare, where they're struggling, they are really struggling because they get a lot of inquiries from new companies, new technologies. And, you know, FDA is a nonstop machine of approval. They just crank out approvals every day, every week, every month. And so they all come down to Medicare, knock on Medicare's door, we want reimbursement. So just put yourself in their shoes. It's a tough job. And the other side, the politicians constantly, you know, hammer them. Oh, the national, you know, budget consumption of healthcare is increasing. It was 12% 10, 50 years ago. Now is 18%, and it just keeps going out. This problem cannot be solved on the path that it is here. There has to be a reset where you give a different weight for primary prevention versus a secondary prevention, and the things that we've discussed before. Since you brought this session up, can I throw something we've presented to the FDA earlier a month ago? But this meeting is like, you guys started Kiba 20 some years ago, and your awardees, you know, are all, you know, pioneers in this field. And I don't know how many of you have been to San Francisco or now recently in LA, got into a driverless car. I would like to bring that topic up, is that when do you think we will have a driverless CT readers, meaning a radiologist is out of the loop and we'll be able to have AI to read the scan to the extent that it is important for reading. We know that radiologists don't treat patients. It's the primary care or the referring physician is in charge. Pretty much all physicians have some understanding of radiology. They don't need to be a radiologist. Our position is, at least for primary prevention, for things that are not heavily paid, we should try to get AI to do what driverless cars are doing and reduce the cost, because adding extra readings for radiologists would just add more cost to the system. So we presented that question to the FDA, and we're going to work with them to provide the evidence required. I wanted to see if the panel, you know, starting from you, David, have any thoughts on this? Because imagine a future like 20 years ago.
I get it. I get it. It actually was the topic I was going to turn to next. So you preempted me a little bit. But I think we all recognize the inevitability of these sort of, whether we call them primary reads or rule out reads. It to an extent gets to this idea of some of the things, it's just going to make it faster. You know, the radiologist can do it, but it takes time and it adds cost. And if we can do it quickly and as well. But this is an enormous issue. And as far as imaging goes, as best as I know, there's really, in the radiology world, there's really nothing yet approved formally as a primary read. So I suspect, and you know, I've been speaking to at least one person with some FDA experience that knows about this topic, that this is a really huge issue for FDA, and it's something they're going to have to, you know, work through. But you know, the steps to getting to primary read, this is coming, and so you know, I'm dreaming of FDA being at the forefront of leading this, and you know, groups like yourself, I think, are in discussion. I know the group that I'm with, Claudia Henschke, is leading a project on rule out reads for lung nodules in CAT scan, taking a slightly different approach. But we're working closely with the FDA, and it's really, I've learned a lot about how FDA works. I mean, they struggle with this too. It's not like they're sitting on an answer. They have to work it out. They're sort of thinking it through. And I guess, you know, you saw earlier where Kyle gave the example of how FDA reached out to somebody like Nancy with quantitation to start getting outside, you know, advice. And I think they're gonna be working through this mechanism, and I would really love to hear about that, and then we don't have that much time, so just some comments on that, and then if you can also, and Robert, you alluded to it, the whole issue of natural language processing in terms of reports. I mean, this is another major area that FDA is gonna really have to find their way and work through it. So if you and Kyle could please comment on this, that would be great. And I think we'll have to end the session after that.
Yeah, I'll just do a quick comment. We did have a public meeting 4 years ago or so now, maybe almost 5, on the potential kind of seeing autonomous and wondering where it was. I think it's still going to take time. And I think one of the issues or one of the things we struggle with is, what performance is acceptable? Because there's always a concern of, you have automated software, what's it going to miss? Is it going to miss that big incidental finding that would have been obvious if a radiologist would have been reading the case. So it's definitely is a struggle, and I think it will be an ongoing conversation that we have. But I'll share and give time for Kyle to share her thoughts or anyone else.
Well, I just would say I'm not a very creative person, and so I look back at what we did with the automated Pap smear reading. It's still not a fully automated read, and I think it's a really good model for managing the risk associated with these kinds of products. So we look for continued improvement in the AI/ML devices that brings the ROC curve up, but at the same time, we start working at a very high threshold where some fraction of cases would not need to be read by you, David, for lung nodules, such that we know that at that level of the threshold, only a small fraction are put in the box to not be read by human observers for that task. And over time, as the community and FDA gets comfortable with moving that threshold, because we see that devices are improving and the benefits are outweighing the risks, we can move in a way that allows for more of that to happen, but we can take steps towards it. It's not going to be all at once. Just like the automated cars, don't go in my neighborhood because it's too complex. And so there are places they go and places they can't.
Just
Have you got on one? Have you?
I have not. They don't come to my house. Yeah,
But they're in Phoenix.
they are in
I-
Phoenix.
I'm strongly recommending all of you guys, because you guys are pioneers, to get in a few and feel the future. I think we as a group,
Yep.
we're passionate about bringing innovation to prevention. Could collectively imagine a future where, just like the past 50 years, people would drive through fast food or Starbucks, get their food or coffee. They could drive through a CT scan imaging, get their image done, and go home, and everything is done through AI, and we really don't need anybody to prescribe anything or get the scan and read like David does with his thing, go up and down, up and down. So that's what we're envisioning, hopefully for the next 10, 15 years.
Just a thought on that. A focus is more potentially on a self-driving patient as opposed to the self-driving radiologist.
Well,
Yeah, see, Bruce, this thing is, people go do things that are easy, simple, low cost. And the moment you put it in a fancy place like Mount Sinai and third floor and VIP, that's only attracts the VIP people. And that's what our problem is. Majority of our 550,000 first-time heart attack in the US in asymptomatic population comes from the uneducated, less educated, and low-income population. But we as a whole, taxpayer, pay for it, right? The same thing for lung cancer. 200,000 of lung cancer populations are people asymptomatic. So if we make it easy for them, the same way that it's easy for them to do grocery shopping or a Starbucks drive-thru, if we make early detection easy for them, we have a chance to break the back of this statistics that have been there for
as we see, Mort is passionate about this topic, as he's made it clear. Anyway, we are out of time, as I've been reminded. I want to thank you, panelists, for this discussion. Robert, thanks so much for joining.
Thanks very much.
This was terrific. And Bruce, of course. Thank you.